Hello, can you hear me? Usui, can you hear me?
Very well, yes. Yes, I
Okay,
can.
good. Thank you. Thank you.
Yeah. What? Which one? Yes, she's there. Ego Atibero. I'm gonna bring you this. So just one. Yeah. Speak very fast. I think the battery is low, so please.
All right. Okay, it works. Okay. Let me pull up some stuff here. We are going to get started in about 2 minutes. Yeah, I'm trying to, because I have to step in for the chair, so I'm trying to get my stuff ready. Okay, well, thank you for taking the time to join us for this roundtable session on maternal health. We had a panel earlier in the day where we presented papers. All of the panelists are on Zoom. I'm the only one in person. I have a co-chair, Esther Jailo, she's also on Zoom. So one of the things that I wanted to say, and I'm stepping in here for Esther, is that this conversation is something that is critical, something that is ongoing. In the last section, we established the fact that Nigeria makes up 20%, a little more than 20% actually, of the global maternal death burden. That's a lot. And we rank number 3 in the world next to Afghanistan and South Sudan, countries that we have no business in ranked next to, because we are familiar with Afghanistan's history. We also are familiar with South Sudan's history. And more recently, the federal government launched a free cesarean section initiative as one of the techniques and approaches to reduce maternal deaths. But again, from the presentation we heard earlier, it's not that simple. As the panelists from earlier made the point that, well, there are the issues of infrastructure. You can say free cesarean section, but what if there are no doctors to provide those services? What if these women who critically need those surgeries do not have access to get from their villages or their communities to that hospital where they can actually gain access to those free CS? What about the support system? These are already vulnerable women. What about the support system when they leave the hospital after that CS? What happens to those women? right? So these are some of the conversations that a lot of the panelists are going to talk about today. We have questions for the panelists, and then we're going to invite the audience to participate in this conversation. I am going to, for the sake of time, I'm not going to read the bios, but I will give each panelist about 2 minutes to talk about their work in relationship to maternal health care. We have 5 panelists. We have, let me pull up that bio. We have a mix of healthcare practitioners, community activists, medical doctors, and scholars as well. We have Dr. Esther Ajayi-Lowo, who is, okay, I'm dealing with my own internet thing here, who is at Texas Christian University. She's an assistant professor there. We have Mrs. Christiana Adebo Boye, who is with the Lagos State Primary Health Care Board. We also have Dr. Bidemi Abola, who is with the Lagos State Primary Health Care Board as well. We listened to Dr. Elsie Reed earlier, who is with the Halima Yard Holistic Wellness Center. And then we have Dr. Abiola Akiyode Afolabi, who is with Women Advocates Research and Documentation Center. So I'm going to give you panelists 2 minutes to just talk about your work on maternal health care, and then we will get into the question. And I'll start with the co-organizer, co-chair, Dr. Esther Ajayi-Lowo.
Thank you, Dr. Williams. I really appreciate it. And thank you for taking the chair thing over since I'm here online, and I believe everyone can hear me okay. Thank you all the speakers on the roundtable for showing up. We really appreciate it. And like Dr. Williams said, this morning we had a panel where we talked about, all the challenges and really emphasizing the fact that maternal health challenges in Nigeria are so enormous. We're thinking about funding, we're thinking about other resources, human resources, medical personnel. We're also thinking about access, and then thinking about how to make maternal health care of good quality in Nigeria. But I think one other thing that was so important is to think about how we can also make use of available resources in terms of thinking about the traditional midwives, and think about all the ways that better to want to birth beyond just the medicalized framework, and how we can bring all of this together and have a multi-pronged approach to resolving the maternal health challenge that Nigeria has. And I think it's really great that we have everyone on board. I know that I've worked with Dr. Agbola, right? And then we were involved in health humanitarian projects, training traditional birth attendants while we were, just like getting funding from Kibi Simon and with the U.S. consulates in Nigeria. So I know you'll be able to shed light on the work that you do on that. I really am so happy that we have WATC represented. So Dr. Abiola Akiyode Afolabi just sent me a message that she's unable to make it. She had to go on here for something very important. So we have Ms. Emanuela sitting in for her. And I'd really like to say that one of the documents that really prompted my work on maternal health is WATC's report, where they really interviewed a lot of women in Nigeria about their maternal health care experience, and they republished it in 2008 along with Center for Reproductive Health and Rights. So it is WATC and CRR publication of 2000, and it's called Broken Promise, right? And to think about from 2008 till now, and that's about 17 years, and we still have most of the promises around maternal health care in Nigeria being broken, right? So we would say, oh, everyone needs to go to the hospital, but then everything they need to thrive in that choice is not available. And then sometimes say, well, do not use the traditional birth attendant, but we still do not have enough doctors, enough OBGYN. So it seems that birthers and pregnant people are left in the limbo. And whenever we have policies like the free cesarean session that we talked a whole lot about this morning. We just do not have implementation in place and strategies to implement those policies in place. I also really appreciate that we have Dr. Reed here, who is also working on ground. She's both a scholar and an activist and has a holistic center where she also takes care of women. And I'm glad that Mrs. Christina Adeboboye, who is also a nurse midwife working on the ground, is here. And so from my own scholarly viewpoint, I am amplifying the voices of the traditional birth attendants, who I like to call traditional midwives, and also in particular the Agbebis, who are the Yorubas in Southwest Nigeria. And I'm also amplifying the voices of the birthers, the pregnant people who go to these Agbebis for care of their pregnancy and child delivery and postpartum care. I'm using that to really amplify the epistemological perspective of African indigenous birthing framework, that I think there's a whole lot there that we can tap into. And I always try to emphasize that this is a both-end approach for me. This is not a moving away from the medicalized care or having access to that, because we really need that. And that is undoubtedly an aspect that we should improve on, that Nigeria needs to improve on. But in addition, we also need to know that there's a lot in the African indigenous traditional birthing epistemologies and approaches that I'm using my work to uncover. And I'm in the process of, writing my book to actually amplify these voices. And because I've also worked on the ground with a whole lot of you as speakers, I'm also interested in listening to what you guys are finding on the ground. So we are going by the WHO data and statistics, but I also want to hear voices of all the work that you do on the ground. What are the challenges? What are the strategies that you're adopting? And what more would you like to see? And then how much more can we work together and bridge the scholarly and advocacy and activist divide that we have, and come together to find a multi-pronged approach to resolving this maternal healthcare crisis that we have at hand in Nigeria. So thank you, everyone. Thank you, Dr. Williams.
All right, thank you very much. We will hear from Dr. Bidemi Abola.
Thank you. Good evening, everyone.
Good evening.
I'm happy to be here. As you have rightly introduced, I'm Dr. Agbola, and I work at the Primary Health Care Board. I'm a medical officer of health, more or less as a public health practitioner. And we are drafted to the primary health centers in the local government. So the level of care that we are taking care of is actually the lowest level. We are the grassroots, the PHC system, primary health care system. So what do? We actually, provide services for our women, maternal health services. Of course, we do antenatal care. We have preventive care, a lot of preventive care, screening for our women. So the challenge for us is actually about uptake. We have some factors that are hindering this, the uptake of the services that we are providing. And of course, because we're also in the community at the grassroots, I think we can also say one or two things about community support. So essentially, that's what we do as it relates to maternal care. Thank you.
All right, thank you very much. Let's go to Dr. Abiola.
Everyone, I hope you can all hear me.
Yes,
my name is Emanuela Azo. Yes, okay. My name is Emanuela Azo. I work with Women Advocates Research and Documentation Center, WATI, Head of Programs and Legal. I'm a lawyer, but I also work on program issues. Yeah, no both. So yes, WATI, what do? We are a women's rights organization. We are a non-governmental organization. We are also a not-for-profit organization. We work basically to protect and promote the rights of women. And has been said, we have done a lot of work around improving and promoting women's maternal, sexual and reproductive health rights. And so part of the things we have done is, yes, in 2008, there was a publication on the broken promises publication that was released by WOTI in partnership with the Center for Reproductive Rights. It's titled Broken Promises, Human Rights Accountability, and Maternal Deaths in Nigeria. That report actually x-rayed holistically the factors of maternal death in Nigeria, why Nigeria was ranking at the time second in terms of ratio and statistics when we talk about maternal deaths around the world. And sadly, 17 years after, the situation has not improved. And I would actually want to say, based on the current realities and technologies that we have and improvements around the world, we are actually declining in regards to that statistics. So we have not seen any form of meaningful progress, of course, also because of the very many policies and new technologies. We now have the assisted reproductive facilities ongoing that can actually better improve, a lot of technologically advanced situations that could actually improve the lots of women. Sadly, our situation has not improved in Nigeria. Admittedly, in terms of accessing technology to be able to, Nigeria as holistically is still lacking behind in terms of technology. And also, it's also part of the things affecting us. So what have we done beyond the publication? We have also done a lot of work around Nigeria. I remember also sometime in 2012, we implemented a project that was supported by Mercator. It was called Social and Legal Accountability. It was a two-pronged project that looked at the social accountability and legal accountability to reducing maternal health in Nigeria. So we worked with women at the grassroots. It was a project that was spread across the north, the east, and the west. So we had 2 states representing each of these 3 geopolitical zones in Nigeria. And so the project was social accountability, where women within the community were empowered to be able to demand accountability, basic forms of accountability from the government on maternal health issues. We also had the legal accountability, where lawyers were trained to be able to legally demand legal accountability once a woman's life is cut short. That's a violation of a woman's life due to maternal health complications. The lawyers were meant to respond, and as a result, a case was filed at the Lagos State General Hospital sometime in 2015 when a woman died in Luth, that's the Lagos University Teaching Hospital, from pregnancy-related complications. Yes, she had a C-section from a private hospital in Nigeria, in Lagos State, and then she had complications. She was referred to Island Maternity. Island Maternity referred her to Luth. Luth repaired the woman. However, she was detained in Luth after the repair. She developed eventually, and she was detained because they have a detention ward, because the detention ward still exists in Luth, where women who are not able to offset their medical fees, particularly maternal health fees, when they are not able to offset the fees, are detained in that ward. So she was detained in that particular ward, the ward without light, without proper facilities, and subsequently she developed sepsis and she died in that ward. Because she had been repaired, she was in ICU for a while, she had been repaired and she was fit to go home. However, she was supposed to be coming in as an outpatient for them to treat her surgery, womb, and all of that. But because she was in detention within Luth, she died. And then we went to court, and that's a ballgame. Currently, what is also in court again on another issue around maternal mortality. So these are some of the many things that we do in WOTI. WOTI is also challenging the STOP guidelines. Of course, we heard in sometime around 2022, Lagos State government in particular released the guideline for safe termination of pregnancies. And the whole essence of that guideline is also to reduce the rate of maternal mortality. But for political reasons, the guideline was suspended. So we are currently working in 6 states in Nigeria, and these 6 states are states where these guidelines have been implemented. They are actually operational in those states. However, the level of awareness and implementation still remains very low, and a lot of women still die from access to unsafe abortion. Access to unsafe abortion contributes to the high maternal mortality ratio we have in Nigeria. So there's also a need for us to look into it. I think I would stop there because if I continue to talk about it, I would go on and on. Thank you so much.
All right, thank you. Finally, we will hear from Dr. Elsie Reed.
Hi, good evening. My name is Elsie Reed. I'm a traditional medicine practitioner. I also serve as the PRO for Association of Integrative Medicine Practitioner, and also the research director of Islamic Association of Traditional Medicine. My first encounter with maternal mortality was in America, where I worked as a data warehouse manager in the US Department of Health. One of the systems I built was a reporting system for the Clinton administration. What I noticed there was that the data did not report the culture, fear, emotions, and other things. It just showed how many people died and, some other medical thing. If anybody has seen Clinton report back in the days, that person will understand what I mean. Years later, I developed something called fibromyalgia. And I turned to integrative medicine because I was told that there was no cure. That journey not only healed me, it also redirected my life. Today, I focus more on women and how to integrate traditional medicine and conventional medicine. I would like to say that the devil gave me lemons and I'm making lemonade out of it. So what I'm doing now is I'm actually working on a research beside helping women with emotional support and fertility issue. I'm working on a research, and the research is seeing how we could merge the two together, because whether we like it or not, it will never go away. The traditional medicine will always play a part. And if we ignore it, the more we ignore it, the more the figures will rise. Because I know people, I've spoken to people where they trust these TBAs with their life because they've seen they've witnessed these TBAs deliver hundreds of people, no issue. However, they've seen people go to the hospital and they die there. In some places, a thing of pride that, I got that woman helped me with my baby, and something will ever make them change that perception. So I'm currently, I've spoken to my House of Rep, and he's endorsed it, and I've spoken to somebody that's the chairman of my village, of my local government, and he's working with me. And I spoke to a rep in Borno State, and he's all for it because Borno is has one of the highest numbers. So I believe that mental health in Africa must be clinical, cultural, and community rooted. We cannot reduce mortality. We can keep ignoring what women already trust. Thank you very much, everybody, and I hope to learn from you all today.
All right, thank you. Obviously, you can see there's a wealth of experience across the board here. I have two questions I'm going to ask them two questions, and then I'll come back to the audience for their own question. Like we've already established that maternal health requires really some serious critical intervention, and that we have not moved forward in about 2 decades. The country has really not moved the needle when it comes to maternal deaths. Instead, in 2025, it seems like we're declining. We are actually going backwards instead of actually making progress. So one of the questions that I have for you, and this is something that I grapple with in my own work, my current book project, my second book project is on maternal deaths, dying to bring life, looking at the cultural and political roots of maternal deaths. And I'm at the point where I'm asking myself the question, what does maternal death even mean to this country? Like, what does it, we say maternal death, maternal mortality, what does it mean? And for you, I'm wondering how you would describe the state of maternal health in Nigeria. When we talk about maternal health care and the state that it's in, how would you describe the state of maternal health based on your various experiences and based on the various things that you've seen in the field? Anybody can jump in.
Excuse me, you have not asked me to talk about what I do. I'm the only midwife in the house.
Sorry, Mrs. Adeboboye, we missed you. Sorry.
Yes, I'm here.
Oh, wow.
And
you are actually the very first person on my list. Please go ahead, Mrs. Adeboboye. Sorry about that.
No problem. Thank you so much. Good evening. Hello, and I don't know where you are, but I want to say hello to everyone. My name is Christiana Adeboboye. I'm a public health nurse and a midwife, and I work for Lagos State Primary Health Care Board, precisely under District 3. I'm the Director of Nursing Services, Lagos Health District 3. And also, I am the chairman of National Association of Nigerian Nurses and Midwives, Lagos State.
Okay,
concerning maternal health, I want to say that in the past decades, we have done so much, though the problem is enormous, but then we did not relent. We continue to provide quality as nurses and midwives who are stakeholders in the business, continue to provide quality maternal and child health services. We also try as much as possible to provide improved and coordinated health care services through by ensuring that we have a good ANC care for our clients. We have a quality delivery services. We also provide postnatal care, both in the facilities and at home. We do a lot of health talks. We also ensure that we are, updating ourselves. How do I mean? In recent times, you know that we have moved from the traditional ANC, WHO ANC to that WHO model of group antenatal care. And that is what we provide. Basically, most of our facilities at the primary health care level have gone through it as pilot study, and it's very, very impressive, and it's bringing good results and best outcomes. So it's spreading more to most of our facilities. We have also tried as much as possible to provide emergency or basic emergency obstetric care. That is when it happens, especially in areas that are mostly remote, in areas where we have primary health care service, and we know that the resources are limited, but they can provide, they have midwives and can provide a specialist care at that level to some extent, and then ensure prompt and effective referral as need may be. We have engaged our nurses and midwives at different levels, at the national level, at the state level, and at the local level, on different capacity building that will empower them to be able to save the lives of our women and children wherever they work. We have also tried to do a lot of community engagement, both on government side, on association side, and we as association, we collaborate a lot with non-governmental organizations, with the government and other professional, bodies to ensure that we save the lives of our women and ensure safe motherhood. A lot of things that we do also include reproductive health services and family planning at our doorstep, making sure that all women of childbearing age, they have access to family planning. And then we also do abortal care, and we engage in adolescent and sexual reproductive health services for our young people to ensure that they're able to, reduce the rates of maternal death. Also, the Renew Hope by the First Lady of Nigeria, our Senator Oluremi Tinubu, the First Lady of Nigeria, has initiated the Renew Hope initiative, which is basically to work together with midwives and nurses, empower us, and also provide necessary supplies and amenities, and also help to reduce maternal health. So we have been doing a lot, and we are into male involvement in MCH, so that we have our male that are the decision makers of the home to partner and to work along with us in every home on mother and child issue. So let me stop here so that we can take other questions. Thank you.
Does any other panelists want to jump in? Thank you very much, Mrs. Cristiano.
Yeah. Thank you.
Maybe I will just speak on the question you asked and regarding the state of maternal health in Nigeria. What does it mean? What does it mean to me or to the work I do? Okay, I think we want to talk about the state of maternal health in Nigeria and how it also impacts maternal mortality issues generally in Nigeria. I'll take it from, I think it has 3 or 4 perspectives. I'll take it from the point of accessibility, availability, affordability, and acceptability of the maternal health care services operational in Nigeria. Of course, we know when we talk about maternal health, we can't but talk about these 3 A's. In some instances, we are referring to it as 4 A's. I would want to go the long haul and talk about it from the perspective of the 4 A's. I'll start from availability. How available is maternal health service in Nigeria? Of course, when we talk about the availability, we're talking about the proximity to, we're talking about the services itself. For example, how many in our communities do we have primary healthcare services that is the first point of call for women? Primary healthcare services. How equipped are these primary healthcare services? Aside from, let me say, urban cities like Lagos, even within Lagos State, there are areas in Lagos State that we cannot boast of accessibility. When we talk about interior areas like Ikorodu, areas like that, Epe, and all of those areas, how available is this maternal health service within these areas? And then now we are talking about accessibility of it. What is the proximity from my house for a woman who is pregnant? How accessible is it? And even the facilities for a woman who is pregnant, or for a woman who is a person with disability. You have your theater room on the 2nd floor and the woman is on a wheelchair, or even when she's not on a wheelchair, she's a person with disability. How accessible is the infrastructure itself? How available are skilled birth attendants, medicines, and other necessary facilities? We still have situations whereby women are made to provide completely as little, as minute as hand gloves for their birthing processes, deliveries. Hand gloves, the minutest of it all, the women are expected to provide. And also, if you also look at the economic situation of Nigeria, which will now take me to the affordability of healthcare services in Nigeria. And if you look at our economic ratio, our current economic reality in Nigeria, how convenient is it for the poorest of the poor in Nigeria to be able to afford quality healthcare service in Nigeria? And how acceptable? Because we still have maternal health services in Nigeria that are discriminatory to people's religion and faith and biases. So how acceptable is our healthcare services? If you look at it holistically, looking at these 4 approaches, we will see that we are not ready as a country. Because if you also look at the budgetary allocation of Nigeria towards maternal health care, it took a very long struggle before the federal budget was started allocating specific line items on maternal health services. We used to have generic budgets that talked about health. But what are those specific health budgets that talks about maternal health services? And then when we talk about allocation in the budget, now what is the level of disbursement? It's one thing to allocate money for them to be able to provide holistic health service, availability, syringe, and all of those. Is another thing for the money to be released. Is another thing for the money to be judiciously spent. So if we take all of these perspectives, if we take all of these issues in holistically together, we would see that for me, maternal health is still a far cry for Nigerian women. Particularly when I talk about maternal health, I do not refer to average Nigerians like myself that can conveniently go to an average private hospital. Even those private hospitals are not cheap anymore. So I look at it from the perspective of the vulnerable, and these vulnerable women are in the majority of the population. They are the worst hit. And then in terms of maternal death, maternal death, usually there are different stages. Some, of course, we have maternal deaths that arises delivery and also post-delivery, and then also during delivery. If you also look at all of these statistics, you would see that for us as a nation, we are not ready. We are not there yet. I agree. Some states, Lagos, well, maybe, Abuja, well, maybe, are trying. But to be honest with you, in terms of trying, there's still room for a lot more to be done. There's still room. I'm not here to crucify to say nothing has worked. Things have worked. However, those things that have worked are really very minimal compared to the population and the current reality of the country and the current reality of growth in the nation overall, in the continent globally overall. So for me, if you also look at, I think there's also a need for us to begin to also work extensively. I agree with, I think it's Dr. Elsie that spoke about traditional birth attendants. We cannot take it away from our system. At a point in time, traditional birth attendants were registered and trained. I think it's something that we should take more seriously than it is ongoing. I know we have choose community health extension workers, we have real traditional birth attendants. So one of the things that because we can't take them away from our systems, and of course also they also contribute to this maternal mortality ratio. So having known and having realized that there are a key component to the maternal death ratios that we have, I think what we should be doing and be looking at as a country is see how we can integrate them holistically into the contemporary and what to call it, not traditional medicine, to the medicine, like contemporary medicine, by training, retraining, and registering them, and making people also, for me, those are the things that we should be looking at as a country currently. Thank you.
Thank you. Does anybody else want to jump in?
Yes, I would like to jump in. Thank you, Barrister Manuel Asu. I wanted to be sure that I address it appropriately. Thank you. And I'm just really going to piggyback also on Dr. Williams' question about like maternal death. What do we even mean by that? And I think I wanted to expand on thinking about maternal death. Where do maternal deaths often occur? I think that's one big question. And I'm asking this because I'm working through this in my work where there's that assumption that more maternal deaths occur with the traditional midwives than the hospital. But I'm not sure who is measuring and who is counting. So that's one big question that I'm hoping that Dr. Agbola, who is a medical officer of health with the Lagos State Department of Health, might be able to shed more light onto that. So is there a way that, do we have data of, someone who dies with a traditional midwives? Do they have to report? People who die at the hospital also, for instance, do they report? Because if we go by what we know and what I've also experienced and my family members and all that, when anything happens at the hospital, you go back and then they tell you your case file is missing. I lost a baby, they said the case file was missing. So I'm not sure if that was ever counted. And also lost a cousin. Until now, we were not even given the case file. It was UCH Ibadan. They couldn't find the case file. It was difficult to actually even press charges. This has been since 2011, and we're still on it because the other husband is not giving up. And this is one of the things that traditional midwives would say, that they work within the community, and the women and the birthers, pregnant people know them, and they are accountable to them, and that the police is also after them, the state government is watching them, and that there's no way that we can prove that they are the ones killing the women, and the women are still showing up in their clinics in high numbers. So they would say, but people who go to the hospital and die, who is counting, who is watching, who is holding them accountable? So that's one question. Another question that I'm also asking is, people who die, during the postpartum stages, how do we count that? Are we counting? Are we counting people who died due to unsafe abortion? Are we counting people who now are accessing the reproductive health technologies, IVF and all of that, and things that happen within that zone? Are we also counting? Are these numbers going into maternal mortality rate index and ratio? How are these things counted? Because when I look at the WHO, I'm like, okay, I still wonder how they get about this number. And I also spoke with one other medical officer of health, and she told me she is in I think Ogun State, and then she said they are actually not required, right, to provide numbers of maternal death. So it's more like, are we actually counting? Do we have more than the numbers that we're dealing with, right? And who is holding who accountable? These are just questions that I'm asking because they are coming up in my work. Thank you.
Thank you very much. Let me just make a correction, please. We need to understand who a traditional midwife is. We don't have traditional midwives. We have traditional birth attendants. They are not midwives. Please, can you remove that midwife behind it? Midwives are people that are trained and certified by the Nursing and Midwifery Council of Nigeria. And we also have doctors who are trained to take delivery. So please, can we get it clear so that we don't mix it up? Those people in the community, they are either quacks or traditional birth attendants. In fact, they practice herbal medicine. So they are not in orthodox field at all. So please don't attach the name midwife. They don't have that midwifery qualification, so that we can, get the discussion a bit clearer. Thank you.
I appreciate that feedback, right? And in my work, I'm referring to them as African traditional midwife or African indigenous midwife. Because people that I spoke with are called Agbebi, for instance, in the Yoruba setting, in the southwest Nigeria. And they have body of African indigenous basic knowledge that have been passed on to them from generation to generation. So that validates their work. And I know there's this binary also of traditional birth attendants and skilled birth attendants, which seems to portend that the traditional birth attendants are unskilled, and I'm working through that in my work as well. So for me, in my work, I either refer to them as their native name, their Agbebis, which is what the Yorubas call them, people who help bring life to being, right? And I think that also matters very much. And I'm writing a section on that as well, because terminology also matters. So the assumption that we have about TBAs, that terminology has been so connected with like their quack, they don't know what they're doing. So one thing I'm differentiating is the WHO in 1992 talked about TBAs as anyone who has had apprentice or training to be able to assist other people to give birth. That was 1992. But when I speak with these people who are Agbebis, these are people who the body of knowledge of African indigenous person have been passed from their generation, from their lineage. And I'm trying to differentiate that from the general TBA or the auxiliary nurse who has got some training from any private hospital and who is also calling them herself or himself a TBA, because these are so different. So when I encounter them on the ground, I see the difference between those who are just maybe TBAs who got trained by one other person. This other set of people who have African indigenous birthing epistemologies and practices that they've been carrying over in their family for decades, even pre-colonial era. And so that's my own viewpoint. That's how I come into this work and in terms of naming and terminology. So I appreciate your feedback, but I also thought that in there to clarify the reason that.
Okay. Are they back? Can you hear us?
Yes, we can hear you. We can hear you.
Okay. I find it very interesting when I hear people call traditional practitioners quack. It's sad because back in the days, that's all we knew until due to politics, everything changed. As a traditional practitioner, I would like to say that not all are quacks. And just like Dr. Esther said, most of them, although they didn't go through formal training, that's going to school, the Western training, they have been taught, it's something generational that has been passed from their great-grandmother to their grandmother and to their mother. And they have learned, in America, Dr. Esther will agree with me that most time, like I have a lot, I'm certified to my teeth when it comes to IT. However, nobody has ever asked me for my qualification. Nobody. What they're interested in America is, do you know how to do the job? How will you do it? So just because somebody went to, no, with all due respect, just because you've been to school and somebody else did not go to school, does not make that person a quack. And then I would like to talk also about the training. Hello? Yeah, can I go on?
Yes, wrap up briefly.
So about okay, no, that's okay. You can. I was going to talk about the training because what I'm advocating for is not just the training; it's also documenting herbal medicine. I'd like to know
various classifications,
So,
traditional medicine,
for me,
midwives, etc. All right, we have
can I
a
go
back.
on?
Who is
Okay.
who's speaking? We lost you briefly.
Okay, Dr. Agbola on the floor.
Oh, okay. Yes.
Can I go on?
Go ahead. Yes. Go on, and then we'll hear from Barrister, and then we will move on to the audience. We need to get to the audience.
Okay. So for me, from the literature, I think I'd rather say the midwives are actually the skilled birth attendants, and every other one that doesn't have a formal training, we refer to them as the TBAs. But the SBAs, the skilled births, are actually the ones that have the formal training. That's for me as per the clarification. Yes, I also believe we should go over some issues about TBA. I don't think I have TBAs taking delivery. We have a whole lot of factors actually affecting access. And just like Dr. Hessia said, these are people that are within the community into the picture, because we've to realize that we may not be able to access, the formal sector may not be able to access everybody. So there's been an integration. So the challenges are, however, that for Lagos State, for instance, in Lagos State as one way or the other has, been trying to them to come forward and register. They have a board, traditional medicine board, which is coordinating this. So they've been asking them to come forward and register. And those that have registered are actually, the practice are actually being monitored. They also have what they do at the local, with us at the PHC level. But then the question or the challenge is actually what percentage are registered? Quite minute, few. A larger number are outside practicing unsafe practices without being registered. Those are the people that are posing threats to the women. The ones that are registered, that are coordinated, they have been trained. They go to Highland Maternity, they train them, they tell them what and what are obtainable, what you should do, HIV screening, things like that. Safe practices while taking delivery. At what point do you refer? Prompt referral.
Right.
But a larger number are not coming forward, and they are there in the community, and taking delivery. Now, also in Lagos State is actually doing a lot, as Barrister said. Although we are not there, but I can say categorically that Lagos State is actually doing a lot. Currently, the Lagos State has been tracking deaths. We have what we call MPDSR, maternal death rates, whereby at secondary facilities, and also think even at the tertiary institutions too, every maternal death are reported and they are audited monthly. So these maternal deaths are referred to their primary, attract to their primary point of referral. Are they coming from the also doing community maternal death? Although I don't think it's in all the local government. I think is a pilot, maybe in 2 local governments. So they've also started doing maternal death. So I wouldn't know, as Dr. Esther said, are we tracking that from productive health, post-aborter? No, I'm not too sure. But the Lagos State is tracking maternal deaths, both from the facilities and from the communities.
All right, let's get to Barrister. She's had her hand up for a while. So let's make it brief, keep our answers brief, keep our questions from the audience brief as well. Barrister.
Actually, the last speaker, I think Dr. Aboyede actually has said a lot of the things I wanted to say, but let me just quickly re-emphasize that in terms of tracking, I think to the best of my knowledge, okay, first, let me just go to the conversation around TBAs. She has actually, I think it would, for terminology's sakes, particularly within our context, it will do us a good service if we actually strictly differentiate and not use the general terminology of midwives as midwives, standard midwives as known world over. I would rather for terminology, use of terminology, let's use the word traditional birth attendants or as traditional birth attendants. I do not disregard their service, but like she actually also said, I've done a lot of work, I've done a lot of research in communities in Lagos, documentaries and all of that on 3 different occasions. So I can actually attest to the fact that there is a registration ongoing and very few. I actually also interviewed some skilled traditional birth attendants that are insistent on and adamant on not registering with the Lagos State government because they believe it's a plot to clip them. And so they do not understand the limit when to refer, because so they go the long haul, and in most cases that's why I use the word they contribute to the high maternal mortality, because at the time of referral, when these people are referred from the traditional birth attendants to the hospitals, it's most times often too late for any form of remedy or suing any health facility, any medical doctor that a woman dies while giving birth from their facility. We had a huge fallout with Sogon because of the maternal death review that has the no shame, no blame factor. It's a death review that once you come, of course, we all understand, they just they do an audit for them to be able to improve on. And I remember one of the statistics and the data that Sogon shared with us. A lot of the deaths that they had audited came from referrals from traditional birth attendants. Particularly, maybe I should use the ones that are quacks within them. Permit me, I don't have that. I'm not supposed to make that general classification. But a lot of the deaths that were audited, the reports that were shared with us came from these traditional birth attendants. So I think for me, there's a need for us to distinguish in terms of statistics and maternal mortality, maternal deaths. Actually, if you also look at the data, like prepartum, postpartum, and all of those data, most of the deaths that actually contribute as well are deaths that actually also arises during and after. These are the deaths that are recorded. These are the deaths. Most of the deaths that happen prior to delivery, they most times do not get to the hospital. So most of these deaths there is no data to show the number of deaths prior to delivery, but also that data is really very high, and that is also because they fail to access antenatal services. And most of these antenatal services, a lot of things have been said here, but for me, actually what we should be doing currently is to go back to the community, go back to the grassroots. The Lagos State government should have a more radical drive to bring on board traditional birth attendants, because if we are going to reduce the maternal death, not only Lagos State, Nigeria, the whole 36 states in Nigeria, if we are going to reduce our ratio, our data in Nigeria, we have to be very intentional. We have to be deliberate in working with traditional birth attendants, registering them, training and retraining. Until we do that, we are not actually serious. And we have to be very intentional. Have a budget line that deals with traditional birth attendants, supporting them in terms of their facilities, in terms of the equipment they use. It's a whole lot. I think for us to be able to reduce maternal deaths in Nigeria, we need to be very intentional. We need to be very deliberate in working with traditional birth attendants. We cannot remove them from our system, our tradition, our maternal health conversations in Nigeria. Thank you.
All right, I do want to add that as far as terminology, to your point, Barris, and to other points, there's established terminologies in the academic circle and in the history of medicine circle for these practitioners. There's traditional midwives for the indigenous African midwives or indigenous midwives, period, the category that Dr. Esther described of people who have this generational knowledge. There are TBAs, those who have received trainings as TBAs, and then there are nurse midwives, clinical midwives. So there are those distinctions that exist. And I do see your hand, Mrs. Christiana, but I'm going to. All right, so
I want to say that, like I said earlier, that a lot of work has been done right from the federal ministry level to the state level, the primary care level, and also in our community and so on and so forth. But let me speak specifically about Lagos State, because the present government, under the leadership of Mr. Babajide Sanwo-Olu, as a team's agenda, and health specifically has worked tirelessly in the sector to make sure that there is access, to increase access to healthcare services through insurance cover for all the citizens of Lagos, so that at any point in time they can afford to access healthcare services without, doing that out of pocket expenses. Also, the same government has worked tirelessly to engage the traditional birth attendants, even to the extent of inaugurating a committee to look into the operations in Lagos, to also develop a curriculum that will be in tandem with what they are, they are meant to practice and practice safely in the community. So a lot of work has been done. And also in the area of capacity building, there have been a series of training and retraining for hot-skilled birth attendants. So I don't want to take too much of your time, because we have done a lot, but I think that we are still doing more. But for me, you ask me, for what Lagos State is doing, Lagos State is really putting in a lot in this aspect to bring down the mortality rates. And that is why you can see a fair figure in Lagos and other states of the country. Thank you.
All right, thank you very much. We will take 3 questions from the audience, allow them to answer, and then we'll go to the online question and we'll continue. Question 1, 2. Okay, so 1, where is 2, 2, 3, and then we'll go online and we'll come back to you and the others. Okay, first question, keep it brief. Name, affiliation, question. You can move up because this can't move, so. And then you can speak as well.
In my research. I can ask about my research today.
Okay, that's fine.
Yeah. You don't have to do that. All right. Hello. I'd like to appreciate your insights, and thank you very much. My name is Muhammad Joji from Bayero University, Kano, Nigeria. My question is on the concept of reproductive health in northern Nigeria. So, as a modern political economy issue, not older than 30 years old, So I'm interested in writing about the history of the professional network of the traditional nurses, which in our locality we call them the Ngozoma. So what I want to do is that I want to go for a long durée research, like going back to the 19th and early 20th century. So I'm driven by the goal of recovering the understudied voices, revealing the importance and what they did, particularly in bus spacing. So is it safe to go with a jargon like a history of maternal and reproductive health through the ages, a history of medical geography, medical history in northern Nigeria, or I should remove reproductive health since I'm talking about the 19th and 20th century. So I will appreciate your advice on how to problematize this research into the scope. Thank you.
Okay, thank you. Question number 2.
Okay, good evening, everyone. Good evening, everyone. My name is Rofer. I'm from the University of Ibadan. And I want to appreciate this panel. It's very important. But my question is to all the panelists. I want to ask, a lot has been known concerning maternal health and the terms of maternal mortality. But, you have beautiful policies written in paper, some, this executed. Have you considered contextualizing this policy? I'm going to cite an example. You said a lot of things, but in terms of cultural competence, when it comes to health workers, I mean health workers hostility. I was at a PhD working outside Ibadan, and a particular woman narrated a story which I confirmed that the nursing, the health workers at the PhD, when she had a first pregnancy, abused her to the extent that for days she was just crying. And when she got pregnant with the second baby, she did not go back. She rather went to mission. TB, we call TBA. And I think we need to address that. And I want to know how you are planning to address such incidents. I know you are not ignorant of what I'm talking about. Yeah. Then another thing is that in health, we give declaration, we make statements. It's fine. We need to make declarations, we need to make statements, but we also need to bring it down home. We also need to bring it down to people. We also need to see how this can fit into our everyday taking for granted reality. And I think by that, if I get maternal mortality, I can keep going on, but I think maybe I shall allow panelists to respond. Thank you.
All right, question number 3.
Yeah, my name is Precious. And I want to appreciate the discussants on discuss. So, for what are you actually referring to? And then this non the traditional register that few of them are registering and all that. So I was thinking this non-traditional attendance or whatever, that if they register on the other hand, they stand to be immersed into this westernized type of practice based on midwife. Okay. So my question is this: is there any room for kind of collaboration between these practices, both traditional midwifery
And the clinical midwives?
Westernized work? And then, what are the benefits of registry? What kind of guarantee does these people have? Because I feel like there's no guarantee. They'll ask themselves, what should I register? But I know a woman that at such delivers children presently. This was a bright time. Okay. So, and she knows that feeding young people come around and there has never been an issue. So that kind of facility, they're telling her about it, she asks you some questions. And if this person should not register, based on the Nigeria we all do, at some point they'll trying to extort from you or something like that. It's predictable, yes. And then the primary health care, someone says something here, due to the lack of funding and have some educational facilities that they need those. So why are you trying to incorporate this with us? Yeah, that's join you to start the same thing you are doing and something. Meanwhile, they are only people poor. So I feel this kind of this just like
Okay, so in sum, what is the benefit of registering? And what does registering mean for the traditional birth attendant? All right, I'll let the panelists respond. Please keep it as brief as possible so we can get to some more questions, another set of questions before we wrap up.
Yeah, I'd like to quickly take the last question to think about registering, what's the benefit and all that. And I'll just link that up to the thoughts I've been having as we've been talking about, training the traditional birth attendants. I've spoken with a lot of traditional birth attendants in Lagos, Ibadan, and Abeokuta. And one thing that is common with them is when they go for this training, one of the things is that they feel like they are being trained as like you do not even know anything, and this is the authoritative medical expertise, and we're just training you. I've also been part of that training, offering that training to them, and we're always going with that mindset also. So I think that seeing them also as people who have knowledge, and then make sure that the training is respectful of the knowledge that they already have, the existing knowledge, I think that would be helpful. I think also when they, refer people to the hospital, that, Western medical midwives, OBGYN and doctors would also, be able to like take those in and not turn them back based on the fact that, well, you've been to quite another. So I think it's also an epistemological question, trusting that some of them who have inherited these intergenerational better epistemologies know something, know what they are doing, and respecting that. I think that would, foster, better integration. And then it's just being shut down. Just, there's just a whole lot of the reason that some of them are afraid to be registered or will stop going to the training. And some who are women amongst them also feel marginalized because they think all of the leadership position in the West traditional medicine board in Lagos State, for instance, are held by men, male traditional birth attendants. So women felt like they don't have a voice in that. So there's also that gender thing that they're talking about. These are some of the things I think would be helpful for the training to be better received, for the registration to be better done, and for them, for the traditional birth attendants, quote and unquote, now to also cooperate with the government so that everyone can work together. Thank you. And I think the first question, I would like to throw that to Dr. Williams, since it's a historical question and then about reproductive health.
Okay. All right. Any other answers from the panelists?
Yes.
I'll take the second question very quickly. That was talking about community, contextualizing the policies and all of that. I think if I got that question very well, it's talking about contextualizing policies and then practice, what the practice is. And I want to agree with you that we cannot take away cultural and social practices as part of the factors that contribute to the maternal mortality issues we have in Nigeria. Agreed. When we talk about cultural practices, beliefs around delivery and birthing processes also contribute largely. You hear statements like, oh, I will deliver like the woman of Hebrew and all of these kind of statements. Yes, we are very religious people and everybody wants to deliver like the women of Hebrew and all of these kind of things. But there is a place for your physical health in the delivery process. Which cultural beliefs usually take away physical health from the maternal journey, and then also socialization. Yes, there's improvements. There's improvement when it comes to healthcare, health workers' behavior, all those health workers' behavior. There's improvement, but honestly, we still have a long way to go. Also, beyond health workers' improvement, there is also the health-seeking behaviors of women themselves. You find someone who is pregnant and is not accessing antenatal service until 5, 6, 7 months. Although I find something really very interesting. In recent times, I note there are also, sorry, before I go there are also practices that also affect all of these issues. For example, when we talk about spousal blood donation, a woman is pregnant and you are demanding the woman's spouse to donate blood. Oftentimes, a lot of factors contribute to a woman's pregnancy. She may not have a spouse. Sometimes people are pregnant as a result of rape. Sometimes people are in abusive relationships and they are pregnant. A lot of factors. And then you go to a government-owned hospital and you are requesting for the woman to bring her spouse. We did a case against the Lagos state government in the tenure of Raji Fashola, and we actually went to court to say you cannot, because the practice was so bad that it has to be your spouse that would come and donate blood. And we are saying to them that, agree, you are trying to populate the blood bank, because we know that blood is an essential tool for delivery, because at delivery you don't require notice. A woman may require what's it called, blood transfusion. However, you don't make the process of antenatal becomes a requirement for populating the blood bank. So you see, there are a lot of cultural, social practices and beliefs that also impacts these whole conversations we are having that we really need to look into. Then when a woman cannot donate blood, she's made to pay a certain amount of money, which goes to the affordability of health service, maternal health service, the conversation around affordability. So you see, a lot of this conversation is something we really need to look critically into to see how we can remove these barriers. Because for me, there are barriers that affect women that eventually contribute to the maternal ratio that we have in Nigeria. And honestly, we also need, I've experienced it too. I would be specific at Randall. At they have this mother and child hospital around there where a woman came for antenatal. Agreed. I think she was birthing her fourth or so pregnancy. The nurses were not nice. They were not nice. I'm sorry. They were not nice. They said all sorts of hurtful words. Ah, madam, you don't come again. You know, all those kind of things that if she was not a woman who is determined to birth her children within in the hospital, she would never access clinics again for her antenatal. And then I also see the question of women. There's a law that you have to be 14 weeks or thereabout pregnant until you can access antenatal service. That's, for me, as a lawyer, I need a lot of education. Why that clause is there. 14 weeks before you can access a government-owned hospital for antenatal. I think for me, I also join my voice with the second questionnaire to say we need to improve on our cultural and social policies and practices to improve our ratio on the maternal death indices around the world. Thank you.
All right, thank you. Mrs. Christiana, and then we'll go to the question online.
Thank you very much. I want to appreciate everyone that have spoken to answer these questions, and especially the last speaker. I also want to make it clear that there is a lot of improvement. I am not here to defend, but I'm here to tell you exactly what obtains and how we can improve care and save the lives of our women. Specifically, when you go to facilities, when you see a lady, everybody assumes that lady is a nurse, especially when they wear scrub or uniform. And then when you see a male, they assume he's a doctor, and that is not really true. So there are different personnel that works in the hospital. However, respectful maternity care is the mandate that we all have, starting from the midwives to the doctor to everyone who attends to clients in the hospital, especially pregnant women and children. So all this verbal abuse need not to occur in recent time. I want to believe that probably it happened a long time ago, but I want to say of recent, you will hardly find things like that because we have done a lot of training and retraining. And of course, we have feedback mechanism where we can, get complaints directly, even up to Mr. Governor. So everybody is on the watch, and you know that passionately, midwives, they are saddled with that responsibility of caring for the women and their children. So we can also work together that the traditional birth attendants that are around our communities, they work together with us. We encourage them to register. If they don't register, they cannot be traced, they cannot be tracked, they cannot be trained, they cannot be empowered. And the disaster will go anywhere. It can continue. Nobody knows who is who. But we can identify those people that are registered people working in the community and as such support and empower them. There are lots of things that are going on, continuously on a daily basis to ensure that we bring a stop to this maternal mortality in our community. Thank you.
For the sake of time, we'll go to the online. We'll see what they get to. And for your question,
now we are talking.
I'll address your question. Go ahead. Let's get to the question online. We lost you a little for a minute there, and then continue. Can you read Soshima's? I can read it if you want.
Soshima's question: what concrete actions are we made in Nigeria's sexual health, taking forward the alarming rates of maternal mortality? Beyond holding positions, how are they utilized currently? Driving advocacy and leading national campaigns to save the lives of mothers across the country, especially in underserved rural areas. The system where maternal health falls through the cracks, very serviceable and transformative leadership.
I don't know if you can read the question if you're online, but it's basically asking what actions the Ministry of Health is taking to combat maternal mortality rates. I don't know if any of the panelists can address that quickly.
Yes, I can address that. Thank you very much. At the level of the ministry, I said it earlier that both the federal, the state, and the local government, everybody is working together to ensure that we reduce maternal mortality to the minimum. However, our target is the SDG 3.1 to ensure that from the 5:1 ratio of maternal death, that is 5:1 to 100,000 live births, we go down to 70 per 100,000 live births. And everything is considered in this. Number one, starting from provision of care, up to provision of essential services, infrastructure, as well as capacity building, as well as data. We collect data, we monitor our data, we use our data. Because without data, we cannot specifically work on this successfully. Because data enables us for researches that will enable maternal health best outcomes. And so we also do a lot of community engagement too on that level, on the level of the ministry. And then this family planning issue is something that has gone a bit more deeper, as in providing family planning services all over the state at free cost, at no cost, providing even the consumables that are, that will have brought hidden costs, making it free, making it accessible to people. And a beautiful thing that the Lagos State government also did is to have this health district, that is making sure that you have all these primary health care center in the local government divided into segments, such that we put them in districts, and so we can have more interface with the grassroots people. We can also serve them more. We can also supervise. We can also work with them, and it has yielded a result. Improved our data, improved the health of the people, making sure that people get all the health services that they really need, including the young people, because the young people, whether we like it or not, they contribute to a large amount of the maternal death, because they are more in our population. We have about 25% of our population that are young people. And so we see that teenage pregnancy, post-abortion or abortion, and all other things that are peculiar with the young people are still there. And so they contribute a lot to maternal death. So working alongside with them, engaging the youth, that is the youth inclusion in the health sector, has really helped a lot. And we are still doing more. Let me just stop here.
All right, thank you. We borrowed a little time. So we have about 7 more minutes, and we are going to take 3 questions from the floor, and then that will be it. We'll wrap up. So keep your questions brief, keep your answers brief. Who was yes, one? Go ahead.
Okay. Thank you to all the presenters. And the first information that I'd like to provide is that Nigeria, as of today, we have failed towards our targets for SDG Goal 3.
Oh, yeah.
Which is to reduce that maternal mortality ratio to 70 per 100,000 live births. 70, that is by 2030. Records in 2003 shows that our MMR is 993 per 100,000 live births. And it has also shown that if we are to achieve that SDG Goal 3, our average annual reduction in maternal mortality must be 34.5% yearly. And Nigeria, since year 2000 to 2003, our average annual reduction in MMR has been 2%. So if in the last 23 years, our annual reduction rate has been 2%, tell me how we can achieve 34.5% yearly between now and year 2030. So technically, I would even want to say that it's a negative fact, but that is the reality. So what is left for us is to see how we can, managedly salvage the situation. That is that. Now, the second issue is this. I followed through with the whole conversation about midwife, TPAs, and all of that. And one thing I just want to appeal to everyone is that there is need for us to stop demonizing TBAs. I was wondering that before the advent of colonialism and before the introduction of Western medicine, how were our parents given birth to? Was it that they held those pregnancies for decades until Western medicine came in? Yes, we are not saying the traditional process is the best. We are not saying it's the safest. But you cannot throw away the baby with the bathwater. And that is one of our problems. I will not say in Africa, but largely in Nigeria. Because most other African countries are beginning to retrace their path, going back to their roots. But it's only in Nigeria that they give us, instead of you to adopt and adapt, we want to throw away all that we have to make space for that new thing that is being introduced. And that is why we are where we are today. So instead of demonizing TVs, there is need for us to integrate them. They are the first go place for pregnant women. Now, I'm going to give an example. Unfortunately,
we need to.
Lagos State is not a perfect model when discussing the challenges of maternal mortality. Go to other states and you see what is happening there. In most states, their PhDs have no doctors. You see no nurses in the PhDs. What you have is community health officers. And when you talk to pregnant women, they will tell you that rather than go to the PhDs where there are no doctors and nurses, they would rather go to the TBAs because the CHO person or the junior CHU heading the primary health care is not better than that TBA that has over 20 years of experience. And so these are the issues. The issue of tax shifting and tax sharing is there. That is also having the turnover effect on even nurses to even say they want to take up employment in the PhD. But how will a midwife or nurse that have gone through series of training be under the community health officer that is meant to head the PhD? So these are the issues for time number.
Okay, very quickly.
Okay,
so thank you everyone for the panelists. Thank you, I appreciate you for this session. I just got interested in this issue of maternity because I was almost a victim. My mom was almost a victim because I was an overstayed child. My mom told me that she carried me for 11 months. And then when she delivered me, I was 5 pounds. And then she passed out when she delivered me. So, and since then, I've grew up. That's kind of, information that my mom always reminds me that the waist bench that she developed today is because of my pregnancy. And I'm like, that I was so heavy. So then the question is, how do we address ignorance? Sorry, I didn't introduce myself. My name is Miracle from the University of Mississippi. And I'm asking, how do we address ignorance in the path of community health workers and then religious bodies? That's my question.
All right, yes.
Thank you so much. I want to share my experience. And it's not with so my experience is this. when I was doing my MSc research work, I researched the sociocultural factors that influence the use of maternal mortality facilities in the state. And then I was also pregnant. So I registered at all these facilities, TBAs, the teaching hospitals, and even the mission. So at the TBAs, I observed that the women there are afraid of cesarean sections. That is why they decided to register at the mission. They believe that with prayers, with God, I want to deliver like an improvement, climbing the stairs, the mountains, they will deliver by themselves. While at the teaching hospital, they would allow you to try, but when they see that you will not be able to do this, maybe they book you for cesarean section. And this has been the orientation of this pregnant women. How do we go into even enlightenment for these women, not when they are pregnant, before pregnancy, to know the benefit of these places? And the mission, I saw that the woman that was assisting the woman that was assisting the traditional birth attendants could not even do anything. And the woman was telling her that you better face it now because by next month she graduates. And the person that is graduating next month that will not do what is expected would go to open our own traditional birth attendants mission house. Yeah. But the woman will always say that go and register at the government clinic because I might anything can happen. And they will tell them at the mission house, make sure you register at the hospital so you will have the card there. When they are requiring, they won't send you back to us. Right. So this understanding of where the best place is lies without wasting our lives.
Okay. So I will give the panelists have a chance to respond as quickly as possible because we're running on borrowed time now. We're out of time. Any panelists can jump in.
Okay. Thank you. I think in summary, I want to say is even now that we are actually delving into the real causes of maternal death. Because previously what we've been discussing, we seems to be discussing about systemic. Just like Barisa said, there are socio-cultural. We're also talking about economical. There are practices that people have believed in. Just like the attitude too was discussed. Yes, why would I want to go to a facility where I'm not welcome? And they go to the TBAs. These are people, and they treat them like kings and queens. They have trust. The trust is there, So there are a whole lot. So I think it's just now we are talking about factors influencing, what causes delay in accessing care on the part of the women. And these are the issues, Then economic issues too. Many women are not empowered. Educational status, how many are educated? Why? And we also have male predominance, just like Mrs. Adiboboye said. You see, the husband influencing whether they go for family planning uptake. In-laws influencing where to go for antenatal care. These are issues. So aside what is wrong with our system, we also need to look at what are the factors hindering these women in doing what is right, So there are a whole lot of it. And of course, out of pocket, unfortunately, from Nigeria, is so sad. Although, as we said, Lagos State has been trying a lot, but we are not there yet. They're also trying to increase access to universal health by doing health insurance, but we are not where we are meant to be. What we have mostly are civil servants being registered under the scheme. The unorganized sectors have not actually keyed into this, the market women. So we still have people having a delay to access care because they don't have the economic power to do so. Now, in Lagos State setting, just like we have said,
Wrap it up.
We're
We're out of time. So if you can just close up in the next few seconds.
So Lagos State system, PAT system, we actually, and that is what a lot of people are not aware. We have a comprehensive center in one of the LGFCDAs in Lagos State of the 57, where we have doctors manning a 24-hour facilities. So it may not be obtainable in other facilities, in other states, but we have that in Lagos State. Even where they have maternal cases that needs to be referred, they are sent to these comprehensive services first. Then the doctors make a decision to refer for emergency care at the secondary facility. And we don't register at 14 weeks. I just want to react to that. No. And what we tell them is they should come as early as possible because we want to track their ability.
We are out of time now. So we will have to wrap up at this point, but thank you very much. This is a very important conversation and one that we will not finish in one day. I look forward to actually collaborating with all of you on the panel in the future, because these are the kinds of conversations between practitioners, academics, and all that can actually move us forward and get us somewhere. So thank you very much for your time, and thank you for bearing with us, even though we're keeping you from your dinner. All right, thank you. Okay.